Hello, it's Dmitry again. Today we'll be going into a different textbook. We're going into the Step Up to Medicine 6th edition textbook. Today we'll be covering the beginning of the cardiovascular chapter. Specifically, the chapter is called Diseases of, let me just make sure that I'm saying this correctly. Diseases of the Cardiovascular System. So I plan on reading basically the first half, perhaps, of this section, and maybe we'll cover the next section tomorrow or something like that. So again, this is the 6th edition of the textbook. There are earlier editions out there, of course, and I think this is the most up-to-date edition for reference. So let's begin. Chapter 1, Diseases of the Cardiovascular System. Mark Duncan, okay. Chest pain. A, differential diagnosis. Heart, pericardium, vascular causes. Stable angina, acute coronary syndrome, unstable angina, UA, non-ST elevated myocardial infarction, NSTEMI, and ST elevation myocardial infarction, STEMI, pericarditis, aortic dissection. 2. Pulmonary embolism, PE, can have pain with pulmonary infarction, pneumothorax, pleuritis, pleural pain, pneumonia, and status asthmaticus. What about 3? GI. It could be GERD, diffuse esophageal spasm, peptic ulcer disease, or esophageal rupture. What if it's because of a chest wall? Costochondritis, muscle strain, rib fracture, herpes zoster. What if it's psychiatric? Panic attacks, anxiety, somatization? And what about drug use? Like cocaine, methamphetamine use can cause angina or MI. So that's basically giving us a differential diagnosis on chest pain in particular. It could be the heart, sure, but it could be all these other things as well, so just keep that in mind. Here's a little thing called a quick hit. It's sort of like a truth nuke, if that was still, how you say, in vogue, I suppose. Anyway, quick hit. If you suspect a cardiac cause of the pain, sublingual nitroglycerin is appropriate. Also give aspirin if the patient does not have a bleeding disorder. Bear that in mind. B. Approach to treating a patient with chest pain. 1. Rule out any life-threatening causes. These include ACS, aortic dissection, pericarditis with cardiac tamponade, pulmonary embolism, tension pneumothorax, and esophageal rupture. And that's important because if you have a situation where it's an emergency situation, you need to address that immediately because they might just die, We don't need to be worrying about like, oh, does this person have an ongoing issue of panic attacks if the person's straight up dying of a heart attack, Just bear that in mind. Anyway, 2. Assess vital signs. 3. Develop a focused history. Character of the pain, pressure, squeezing, tearing, sharp, stabbing, etc. B. Location of pain. C. Severity of pain. Duration of pain. Setting in which pain occurred. During exertion, at rest, or after meal. Radiation of the pain. Aggravating or alleviating factors like a meal, exertion, rest, respiration. Does the patient have a cardiac history? Ask about results of previous stress tests. Echocardiograms, cardiac catheterizations, or any procedures like PCI or CABG. See, I've done shadowing at a hospital before. I know what CABG is. If the I remember how to pronounce it. To be fair, I shouldn't say that I know much about it. I don't recall that much about it in terms of the particulars. Anyway, is it a coronary artery bypass graft? Am I mistaken? Something like that. Don't quote me on that one. If the patient has a history of angina, ask how the episode differs from previous ones. More severe, longer duration. 4. Perform a focused physical examination with attention to cardiopulmonary, abdominal, and musculoskeletal examination. Number 5. Order ancillary tests. Obtain EKG in almost all cases. Cardiac enzymes like troponin, depending on clinical suspicion. Obtain chest X-ray like a CXR in almost all cases. Under the appropriate clinical setting, work up against the patient for a pulmonary embolism. See pulmonary section. And then 6. Develop a diagnosis. It can be difficult to distinguish between GI causes of chest pain and angina. The decision of whether to initiate a cardiac workup is dependent on a patient's overall risk of coronary artery disease, CAD, and the CAD, and the clinical presentation. There is no fail-proof algorithm for approaching chest pain. In general, have a greater index of suspicion for ischemic causes in the elderly, diabetic populations, and those of a history of CAD. Coronary artery disease. Anyway, see myocardial infarction MI section. Risk stratification scores can be helpful for evaluating patients in the emergency department. That is to say, for example, the heart score. So, I want to say this right now, right here, that this whole thing we're doing right now is basically what you would do when you try to do a patient interview. They tell you, hey, if you're a medical assistant, if you're a doctor, or you could say a medical student who's doing rotations, whatever it might be, they say, hey, give us a patient interview before they actually see the doctor. You know, what's going on with the patient, you know, what's going on, what's their history like that's relevant, you know, what's their social history, what's their surgical history, what's their family history. Just get like a good idea of, you know, what's going on. And there's a way to remember this called Codeirs, Smash FM, and Fed Tacos. You can look it up right now. That's CODEIERS, Codeirs. Smash FM is spelled out the way you would imagine it would be. And then Fed Tacos is the same way it would be the same thing. Just look it up. That's one way you can do an interview with a patient. There's other ways to do that kind of stuff as well, I would imagine. But that's a pretty good idea of it. You need to be aware of the social history, the family history, surgical, medical history, and you also have to be aware of what's the current complaint, and also be aware of like what are the particulars. Is it pain? Is it radiating? Does it come and go? Does it get better or worse? How long has it been? Have you had this in the past? How'd you make it better? That kind of stuff. So bear that in mind. And I suspect that the following chapters will be very similar in terms of how they open up the chapter. They'll give you maybe like, I would assume, some sort of situation. Oh, this patient has XYZ thing. What could it be? And they go through it like that. Anyway, let's go through these quick hits. Quick hit number one, or numero dos in this case. If nitroglycerin relieves the pain, a cardiac cause is more likely, although nitrates also relieve pain from a diffuse esophageal spasm. So basically, if nitroglycerin actually works, more likely to be cardiac. Quick hit over here, another one. If chest pain is pleuritic, positional, or reproduced with chest wall palpation, a cardiac cause may be less likely. Okay. Quick hit. A common presentation is a patient with chronic stable angina who presents with symptoms suggestive of unstable angina. The following are the initial steps. 1. Obtain an EKG and cardiac enzymes. 2. Give aspirin. 3. Begin IV heparin if no contraindications, that is to say active bleeding, recent life-threatening bleed. And 4. Admission to hospital for workup as described above. Oh. Okay. I just realized I turned the volume off. I didn't turn the microphone off. So yeah, sorry. Apologies for sneezing on live stream. You know. Anyway, ischemic heart disease, stable angina pectoris. So let's talk about it. General characteristics of stable angina pectoris. Stable angina pectoris is due to fixed atherosclerotic lesions that narrow the major coronary arteries. Coronary ischemia is due to an imbalance between blood supply and oxygen demand, leading to an inadequate perfusion. Stable angina occurs when oxygen demand exceeds available blood supply, also called chronic coronary syndrome or stable ischemic heart disease. What are the major risk factors? Diabetes mellitus. This is the worst risk factor. Okay. Hyperlipidemia, elevated low-density lipoprotein LDL, hypertension, HTN, most common risk factor, cigarette smoking, age, men over the age of 45 and women over the age of 55, family history of premature coronary artery disease or MI in first-degree relative, men less than 55 years of age, women less than 65 years of age, low levels of high-density lipoprotein, HDL. 3. Less common risk factors include end-stage renal disease, ESRD, on hemodialysis, human immunodeficiency virus, HIV infection, History of mediastinal radiation. Minor risk factors include obesity, sedentary lifestyle, lack of physical activity, stress, excess alcohol use. So these other things can have an effect as well. Prognostic indications of coronary artery disease. Left ventricular function, ejection fraction. Normal would be greater than 50%. If less than 50%, associated with increased mortality. So they're just saying that that will make things worse if that's the situation. Vessels involved severity/extent of ischemia. Left main coronary artery, poor prognosis because it supplies approximately 2/3 of the heart. 2 or 3 vessel coronary artery disease, worse prognosis. Quick hit. Coronary artery disease can have the following clinical presentations: asymptomatic, stable angina pectoris, unstable angina, myocardial infarction, either end-STEMI or STEMI, sudden cardiac death. Second quick hit. Typical anginal chest pain, substernal, worse with exertion, better with rest or nitroglycerin. Clinical features. And I just want to say this right now. Get this out of the way. I was doing these psych chapters because you might be surprised that I was doing, a particular educational opportunity for about a month or 4 weeks. And that switches over every 4 weeks for some reason. I think you can imagine if you were, studying medicine, what that might be. And, psychiatry is so specific, so I can go read very specific, very limited topic. And here's the thing with this book here, is that, when you do, let's say, I could just say, in internal medicine, if you do internal medicine, it's everywhere. It's all over the place. It's all of the above. It's not necessarily psychiatry, but it's cardiovascular, GI, endocrine. Like it's everything and everything around and in between. So that's why this book is going to be, I think, more comprehensive than what we did with the psychiatry textbook. Anyway, clinical features. And we're talking about, are we still talking about CAD? We're talking about stable angina pectoris. Okay. So clinical features of stable angina pectoris. Chest pain or substernal pressure sensation. Lasts less than 10 to 15 minutes, usually 1 to 5 minutes. Frightening chest discomfort, usually described as heaviness, pressure, squeezing, tightness, rarely described as sharp or stabbing pain. Pain is often gradual in onset, brought on by factors that increase myocardial oxygen demand, such as exertion, stress, or drugs, that is to say cocaine or amphetamines, relieved with rest or nitroglycerin. Factors that are less consistent with ischemic pain, but do not rule out ischemia. Pain that changes with breathing or body position, or chest wall tenderness. Another quick hit. It says here, stress testing is used in the following situations: to confirm diagnosis of angina, to evaluate response to therapy in patients with documented coronary artery disease, and to identify patients with coronary artery disease who may have a high risk of acute coronary events. It basically helps us figure out if the person has CAD, and if they do have it, are they at particular risk in a situation like an acute event involving this kind of stress. It helps us get a better picture of what their condition is like. Diagnosis. Know that physical examination in most patients with CAD is normal. Resting EKG, usually normal in patients with stable angina. Q waves are consistent with a prior MI. Yeah, so again, if you have Q waves, think about a prior myocardial infarction or heart attack, right? If you just have a normal EKG, it's probably a stable angina. So if you have CAD and you have the Q waves, think you had an MI in the past at some point. Stress test. Useful for patients with an intermediate pretest probability of CAD based on gender, age, and symptoms. General principles. Exercise stress testing is preferred if the patient can exercise, whereas pharmacologic stress testing is preferred when they cannot. Stress EKG. High sensitivity if patients have normal resting EKG, such that changes can be noted, Patients with baseline EKG abnormalities such as left bundle branch block or LBBB, pre-existing ST segment changes, or left ventricular hypertrophy (LVH) should not undergo stressed EKG testing. Test involves recording EKG before, during, and after exercise on a treadmill. 75% sensitive if patients are able to exercise sufficiently to increase the heart rate to 85% of maximum predicted value for age. A person's maximum heart rate is calculated by subtracting the age from 220. 220 minus age, okay. Exercise, let's say your age was 50, well then you have to have a 170, right? That's the idea. As a maximum hypothetical heart rate. Exercise-induced ischemia results in subendocardial ischemia, producing ST segment depression. So the detection of ischemia on a stress EKG test is based on the presence of ST segment depression. Other positive findings include onset of heart failure or ventricular arrhythmia during exercise or hypotension. Patients with positive stress test result should undergo coronary angiography. Now, stress echocardiography performed before and immediately after exercise-induced ischemia is evidenced by wall motion abnormalities, that is to say, akinesis or hypokinesis, not present at rest. This study is less reliable in patients with existing wall motion abnormalities or lowered ejection fraction. Useful to assess left ventricular size and function, can diagnose valvular disease, and can be used to identify CAD in the presence of pre-existing EKG abnormalities. D. Information gained from a stress test can be enhanced by stress myocardial perfusion imaging after IV administration of a radioisotope such as thallium-201 during exercise. Viable myocardial cells extract the radioisotope from the blood. No radioisotope uptake means no blood flow to an area of the myocardium. It is important to determine whether the ischemia is reversible, that is to say, whether the areas of hypoperfusion are perfused over time as blood flow eventually equalizes. Areas of reversible ischemia may be rescued with percutaneous coronary intervention, PCI, or coronary artery bypass graft, CABG. So I was right. Okay, irreversible ischemia, however, indicates infarcted tissue that cannot be salvaged. Perfusion imaging increases the sensitivity and specificity of exercise stress tests, but is also more expensive and subjects the patient to radiation. So quick hit number 1, exercise stress test. Exercise stress EKG is an ideal initial test if able to exercise and have a normal resting EKG. Quick hit number 2, a stress test is generally considered positive if the patient develops any of the following during exercise: ST segment depression, chest pain, hypotension, or significant arrhythmias, which is more of an indication of like the first one, you say ST segment depression. It sounds like you would have an angina in that situation because you're having basically angina induced by exercise. So that's why you have the ST segment depression. And I'm not mistaken, if it's ST segment depression, that means it's only endocardial. And because if it was full segment thickness, it would be actually ST elevation, I believe. So I would, if I were you, I would look that up. But anyways, so the next point: if the patient cannot exercise, perform a pharmacologic stress test. IV adenosine, dipyrimidol, or dobutamine can be used. Cardiac stress induced by these agents takes the place of exercise. This can be combined with an EKG, an echocardiogram, or nuclear perfusion imaging. IV adenosine and dipyrimidol cause generalized coronary vasodilation. Since diseased coronary arteries are already maximally dilated at rest to increase blood flow, they receive relatively less blood flow when the entire coronary system is pharmacologically vasodilated. These agents are used for perfusion imaging. Dobutamine increases myocardial oxygen demand by increasing heart rate, blood pressure, and cardiac contractility. This is typically used in stress echo studies. Okay. Clinical Pearl 1-1. Types of stress tests. Test and then method of detecting ischemia. So we have an exercise EKG. It's used for an ST segment depression, which helps us detect the ischemia. And I think that'd be let me just verify this for a moment right now. Not sure if that'd be a subendocardial or ST segment depression means which layer? I think I want to say subendocardial. It says here subendocardial ischemia. Yeah, okay, so I'm right. Cool. Next one. Exercise or dobutamine echocardiogram. It indicates or detects wall motion abnormalities. What about exercise or dipyramidal perfusion study, thallium or technetium? Decreased uptake of the nuclear isotope during exercise. Clinical Pearl 1-2. Cardiac catheterization. 1. Most accurate method of determining a specific cardiac diagnosis. 2. Provides information on hemodynamics, intracardiac pressure measurements, cardiac output, oxygen saturation, etc. 3. Coronary angiography, see below, is almost always performed as well as for visualization of coronary arteries. 4. There are many indications for cardiac catheterization, generally performed when revascularization or other surgical intervention is being considered. After a positive stress test, acute MI with intent of performing angiogram and PCI, in a patient with angina in any of the following situations: when non-invasive tests are non-diagnostic, angina that occurs despite medical therapy, angina that occurs soon after MI, and any angina that is a diagnostic dilemma. If a patient is severely symptomatic, their urgent diagnosis and management are necessary for evaluation of valvular disease and to determine the need for surgical intervention. Coronary angiography. Most accurate method of identifying the presence of and severity of coronary artery disease. The standard test for delineating coronary anatomy. Main purpose is to identify patients with severe coronary disease to determine whether the revascularization is needed. Revascularization with PCI involving a balloon and or stent can be performed at the same time as the diagnostic procedure. Coronary stenosis is greater than 70% may be significant, that is to say, it can produce angina. Anyway, let's go back into this. So we're talking 1, 2, 3. 1, 2, 3. We started off with the diagnosis. So let's talk about number 4. Cardiac catheterization with coronary angiography, which will go back to the clinical pearl. Coronary angiography, definitive test for CAD, often performed with concurrent PCI for patients with being considered for revascularization with CABG. This is the best choice for patients with very high pretest probability of CAD. Contrast is injected into the coronary vessels to visualize any stenotic lesions. This defines the location and extent of the coronary disease. If CAD is severe, that is to say left main or 3-vessel disease or 2-vessel disease with concurrent DM, refer a patient for surgical revascularization, CABG. And they say PCI. I'm not quite sure what they meant by that, but let me see. They might have mentioned it before. PCI coronary. PCI refers to percutaneous coronary intervention. So they might have mentioned that before. Anyway, 5. Other imaging studies to diagnose CAD include CT scan with coronary artery calcium score or a CT angiogram. These are typically used in patients at intermediate risk who cannot exercise. And so here's a little diagram here for figure 1-1, coronary angiogram, injection of the right coronary artery shows a stenosis in the mid portion of the vessel, indication by the arrow. And this is whatever, that's the source. What about treatment? Risk factor modification is number 1. Smoking cessation cuts CAD risk in half by 1 year after quitting. Hypertension, vigorous blood pressure control reduces the risk of CAD, especially in diabetic patients. Hyperlipidemia, reduction in serum cholesterol with lifestyle modifications and HMG-CoA reductase inhibitors, as to say statins like atorvastatin, lovastatin, and so forth. These reduce CAD risk. Again, goal of LDL is to be less than 70 in patients with known CAD. DM, type 2 diabetes, is considered to be a cardiovascular heart disease equivalent, and strict glycemic control should be strongly emphasized. Obesity, weight loss modifies other risk factors, for example, diabetes, hypertension, hyperlipidemia, and provides other health benefits. Exercise is critical. It minimizes emotional stress, promotes weight loss, and helps reduce other risk factors. The diet, reduce intake of saturated fat, less than 7% total calories, and cholesterol, less than 200 milligrams a day. Quick hit, number 1. Standard of care for stable angina includes drugs that improve mortality, aspirin, high-intensity statins, or in some cases a PCSK9 inhibitor to lower the LDL even further. Drugs that relieve angina, beta blockers, nitrates, calcium channel blockers, and ranolazine. Okay. What about quick hit number 2? Side effects of beta blockers. Erectile dysfunction in males, irritability, inability to increase heart rate in response to exercise. Side effects of nitrates, headache, orthostatic hypotension, tolerance, and syncope. Medical therapy. Aspirin. Indicated in all patients with CAD. Decreases morbidity, reduces risk of MI. Lower lipid-lowering therapy. HMG-CoA reductase inhibitors like statins lower LDL and reduce the risk for cardiovascular death. PSK9 inhibitors lower LDL even further than statins and have been found to reduce CV events in patients on statin therapy with LDL receptors above 70. LDL levels above 70. Beta blockers block sympathetic stimulation of the heart. They reduce heart rate, blood pressure, and contractility, thereby decreasing the cardiac work. That is to say, beta blockers lower myocardial oxygen consumption. Have been shown to reduce the frequency of coronary events. Nitrates cause coronary vasodilation and systemic venodilation. They relieve angina, help reduce preload and myocardial oxygen demand. They may prevent angina when taken before exertion. Effect on prognosis is unknown. Main benefit is symptomatic relief. Can be administered orally, sublingually, transdermally, intravenously, or in paste form. For chronic angina, oral transdermal patches are used. For acute coronary syndromes, see below, either sublingual, paste, or IV forms are used. Calcium channel blockers cause coronary vasodilation and afterload reduction, reduce contractility. They add to the anti-anginal therapy when beta blockers and nitrates are not fully effective. Revascularization. Controversial for patients with stable CAD, as studies suggest no improvements in mortality and MI when compared to medical therapy alone. Per guidelines, revascularization is indicated for stable angina refractory to medical therapy symptom control. Two methods. Again, that we saw PCI, which was percutaneous coronary intervention, and CABG, coronary artery bypass graft. See Corporal 1.3. Management decisions, general guidelines, risk factor modification, and aspirin are indicated in all patients. Manage patients according to overall risk. Mild disease, normal ejection fraction, mild angina, single vessel disease. You can use nitrates for symptoms and as prophylaxis, and a beta blocker are appropriate. Consider calcium channel blockers, again that's CCBs, calcium channel blockers, if symptoms continue despite nitrates and beta blockers. Moderate disease, normal ejection fraction, again EF is ejection fraction, or I should say, this is what I said right, that's not again, I've said this the first time I guess you could say. But yeah, EF is ejection fraction, but moderate disease, normal ejection fraction, moderate angina, two-vessel disease. If the above regimen does not control symptoms, consider coronary angiography to assess the suitability for revascularization, either a PCI or CABG. Severe disease, reduced ejection fraction, severe angina, and three-vessel left main or left anterior descending disease, coronary angiography and consider for CABG. Avoid calcium channel blockers with reduced ejection fraction. So that's an important distinction. Quick hit. The COURAGE trial showed essentially no difference in all-cause mortality and non-fatal MIs between the patients with stable angina treated with maximal medical therapy alone versus medical therapy with PCI and bare metal stenting. Of course, most PCI is now done with drug-eluting stents, which are superior to bare metal stents with regard to risk of stent thrombosis and recurrent MI. So it might not be totally accurate given modern medical technology, but given the constraints of whatever study they're talking about, it didn't seem to have much of a value in reducing mortality. Clinical Pearl 1.3 Percutaneous coronary intervention consists of both coronary angioplasty with a balloon and stenting. Should be considered in patients with 1, 2, or 3 vessel disease. Even with 3 vessel disease, mortality and freedom from MI have been shown to be equivalent between PTCA with stenting in CABG. The only drawback is the high frequency of revascularization procedures in patients who received a stent, best if used for proximal lesions. Restenosis is a significant problem, up to 40% within the first 6 months. That's pretty serious. However, if there is no evidence of restenosis at 6 months, it usually does not occur. Okay. So really, it just tries to really pull it back in the first 6 months, and after that, it kind of lays low. It doesn't really do much after that. But you're really in this situation of potential restenosis early on. So, new techniques and technological improvements such as drug-eluting stents are attempting to reduce this problem. I'm really interested in sort of the pathophysiology of that, because if it's a 6 months is when it usually pops up. I wonder what's going on with that. Coronary artery bypass grafting. Because we always present stenosis when we think about it. We say, because a guy's been eating fast food and smoking cigarettes and doing all those sorts of unhealthy things people can do, he developed this stenosis over the course of 50 years or something like that. But apparently you can get a pretty nasty stenosis within 6 months if you try to remove it, So it's not so gradual necessarily. Not necessarily. Coronary artery bypass grafting. While CABG remains the standard of care at some institutions for patients with high-risk disease, the pre-combat and syntax trails have shown that PTCA with stenting may be as good as CABG, even in patients with left main coronary artery disease. CABG is still used as a primary method of revascularization in a small number of patients with STEMI. In addition, it may be indicated in patients with cardiogenic shock post-MI. After complications of PCI, again, that's referring to the coronary intervention, percutaneous coronary intervention, in the setting of ventricular arrhythmias, and with mechanical complications after acute MI. Main indications for CABG would be 3 vessel disease with greater than 70% stenosis in each vessel, left main coronary disease with greater than 50% stenosis, and then left ventricular dysfunction. And let me look something up again, PTCA, because I don't remember them explaining exactly what that meant. It means percutaneous transluminal coronary angioplasty. So again, that's percutaneous transluminal coronary angioplasty. I'll probably forget that one. Now we're just on ACS background and terminology. I'm going to take a brief pause. I noticed, let me say this before I do anything else. I'm on page 21. I think we started off on 13 or something like that, 13, 14. I think 13, but it's kind of a slog because I know it's 21 right now. I got to get to page 64 or 65 to get halfway through the chapter. This is definitely a larger burden in terms of reading on my part than what I was doing before. So, I guess it's something I got to deal with, I suppose. Acute coronary syndrome. Background and terminology. Acute coronary syndrome includes UA, NSTEMI, and STEMI. I think UA in this means unstable angina. So unstable angina, non-ST elevated myocardial infarction, which is basically a kind of heart attack, and then STEMI, which is ST elevated myocardial infarction, which is again another type of heart attack. The distinction between unstable angina and NSTEMI is based entirely on cardiac enzymes. Both UA and NSTEMI lack ST segment elevations because it's not a full-throated, full transmural infarction. STEMI, which is ST elevated, is a full transmural infarction, by the way, but these other ones are not. Differentiating them from STEMI, I just said that, yeah, exactly. Unstable angina is differentiated from the stable angina if it has any of the following characteristics: new onset angina, angina at rest without exertion, early post-MI or post-PCI. With the more widespread use of high-sensitivity troponin testing, UA is a rare diagnosis since virtually all cases of ACS will have an elevation in this biomarker. Thus, UA is more of a historical term, and priority in the clinical care is differentiating and managing NSTEMI versus STEMI. Well, that's interesting. So, anyway, because it's becoming more and more accurate, it becomes less and less of a real category and more of just like a hypothetical. Oh, an unstable angina is when you have this sort of like heart, it kind of feels like a heart attack a little bit, but there's no cardiac enzyme elevation. It's like an NSTEMI, but it's not going to have these elevated enzymes because it's not necessarily going to have this permanent damage in a meaningful sense. And the thing is, because the cardiac enzymes are becoming we have more sensitive tests for it, it's going to become more and more obvious that there is some enzymes present, and so everything that would have been considered unstable angina is now considered NSTEMI, even if it's not as severe as the more radical ones you can see for NSTEMI. But I digress. With the more widespread use of, so we went over that. MI occurs in NSTEMI and STEMI, and is defined as an elevation in cardiac biomarker with evidence of acute myocardial ischemia. Well, it's called myocardial infarction, so yeah, obviously. Pathophysiology. With unstable angina, oxygen demand is unchanged. Supply is decreased secondary to reduced resting coronary flow. This is in contrast to stable angina, which is due to increased demand. So, reduced flow versus increased demand. Because you can get unstable angina, for example, when you are let's say you're sitting down and you start having unstable angina, you're just resting. It's not necessarily reflective of exercise per se. But if you're panicking, you're running around and going crazy, and then you have a heart attack and it's transmural, okay, well that's different, Unstable angina is significant because it indicates stenosis that it has enlarged via thrombosis, hemorrhage, or plaque rupture. It may lead to total occlusion of a coronary artery. Unstable angina has a higher risk for MI and death than stable angina, and patients with this diagnosis should be hospitalized. MI is due to necrosis of myocardium as a result of the interruption of the blood supply. Most cases are due to acute coronary thrombosis, atheromatous plaque ruptures into the vessel lumen, and thrombus forms on top of its lesion, which causes occlusion of the vessel. MI is associated with 30% mortality rate. Half of the deaths are pre-hospital. Most patients with MI have a history of angina, risk factors for CAD, or history of arrhythmias. A 2018 Joint Task Force subclassified MI into 5 categories. Type 1 MI, plaque rupture with thrombus. Type 2 MI, a supply-demand mismatch with oxygen delivery. Type 3 MI, typical MI suspected, but death occurs with testing the blood for cardiac biomarker elevation. Type 4 MI associated with PCI. And type 5 MI associated with CABG. Quick hit. Number 1, acute coronary syndrome. The clinical manifestations of atherosclerotic plaque rupture and coronary occlusion, term generally refers to UA, NSTEMI, or STEMI. Quick hit number 2. The combination of substernal chest pain persisting for longer than 30 minutes and diaphoresis strongly suggests acute MI. Clinical features. Chest pain, intense substernal pressure sensation often described as crushing and an elephant standing on my chest. Radiation to the neck, jaws, or back, commonly to the left side. Similar to angina pectoris in character and distribution, but much more severe and lasts longer. Unlike an angina, pain may not respond to nitroglycerin. Some patients may have epigastric discomfort. Can be asymptomatic in up to 1/3 of patients. Painless infarcts or atypical presentations more likely in post-operative patients, the elderly, diabetic patients, and women. Other symptoms include shortness of breath, diaphoresis, weakness, fatigue, nausea and vomiting, sense of impending doom, and syncope. Sudden cardiac death, usually due to ventricular fibrillation, VFib. So just be aware of the arrhythmias that can be caused by it as well. Quick hit. The majority of ACS cases are diagnosed as NSTEMI or STEMI. UA is now rare with high sensitivity troponin testing, again because it's so sensitive. Even if you have a little bit of the enzymes, because you have a little bit of ischemic damage that kills cells and releases the enzymes, it'll still be detectable. So, it is what it is. A 59-year-old woman presents to your office with chest discomfort, jaw pain, and nausea. The symptoms occurred suddenly 2 hours ago and are getting worse. She has a history of poorly controlled hypertension, and she has a 30-year history of smoking. You send her to the emergency department and order some initial tests, which are shown below. Sodium 137, potassium 4.9, chloride is 105, bicarb is 22, blood urea nitrogen is 21, creatinine is 1.3, glucose is 110, and the high sensitivity troponin is positive. An EKG shows multiple T-wave inversions and ST depressions in continuous leads. Which of the following is the most likely diagnosis? Is it A, let me not show the answer. A, stable angina, B, unstable angina, C, non-ST elevation MI, or D, ST elevation myocardial infarction? What do you think? Well, the answer is C. The answer is C, non-ST elevated myocardial infarction. It is important to know how to differentiate between ACS, different types of ACS, since the guides of this course of action as well as the prognosis. ACS is made up of unstable angina, NSTEMI, and STEMI. Stable angina is not an ACS. Fair enough. And typically occurs with a consistent level of exertion that is relieved with rest and or nitroglycerin. However, it can progress to unstable angina, which typically lasts about 30 minutes and manifests as angina without exertion. Angina with a crescendo pattern, or angina that is severe and of new onset. NSTEMI is differentiated from the unstable angina by positive troponins, and STEMI is differentiated from NSTEMI by ST elevations seen on EKG. In unstable angina and NSTEMI, there may or may not be ST depression and T-wave inversions, signs of myocardial ischemia, but there will not be ST elevations. Quick hit. Stress testing only detects flow-limiting high-grade lesions, thus can still have MI despite negative stress tests because the mechanism of MI is acute plaque rupture onto a moderate lesion. Peak T-wave, T-wave inversion, ST segment elevation, or D Q-wave. So these are the four little presentations. So this is what a peak T-wave would look like, this is what an inversion would look like, this is what a ST elevation would look like for, let's say, a STEMI. And that's what a Q-wave would look like. Let's say, for example, you had an MI a long time ago. So you have this little marker at the end. It says here, ST segment patterns. This is the figure. ST segment patterns consistent with STEMI. During the early stage of infarction, with the T-waves tall and peaked. B, within a few hours after the T-waves are inverted. Was interesting development. And then the ST segment elevates, right, lasting several hours to several days. Okay, so it's there for a while. And then Q waves, indicative of infarction, develop within several hours of infarction, but in some patients they do not develop until 24 to 48 hours later. Quick hit. ST segment elevation indicates an infarction at 75% of the time. ST segment depression indicates an infarction only 25% of the time. Yeah, I mean, I guess because ST segment elevation at STEMI is like a full-throated infarction. So yeah, I mean, that makes sense. That's going to be more likely. to be that, because you're not necessarily going to get transmural ischemia and not have some infarction. Diagnosis. Initial approach. For all patients should, at minimum, include a brief history and physical lab testing, including cardiac biomarkers, especially high sensitivity troponin if available, and an EKG. For patients with an initial normal troponin, it should be repeated in 3 to 6 hours. The EKG can be repeated every 15 to 30 minutes to evaluate for dynamic changes. A bedside ultrasound can be also used to evaluate cardiac function and regional wall motion abnormalities. 2. EKG. Markers for ischemia/infarction include peaked T waves occur very early and may be missed. ST segment elevation indicates transmural injury and can be diagnostic of an acute infarct. Q waves, evidence for necrosis specific. Q waves are usually seen late, typically not seen acutely. T wave inversion is sensitive but not specific. ST segment depression, subendocardial injury. Categories of infarcts: we have ST segment elevation infarct, so STEMI. Transmural involves entire thickness of the wall, tends to be larger. For an MI to be categorized as a STEMI, there must be ST segment elevation in 2 continuous leads, 2 and 3, for example. This elevation must be at least 0.1 millivolts, 1 millimeter, or 1 small box in all the leads except V2 and V3. At least 0.2 millivolts or 2 millimeters in men 40 and older, and at least 0.25 millivolts or 2.5 millimeters in men less than the age of 40 and less than 40 years of age, or 0.15 millivolts and 1.5 millimeters in women. Non-ST segment elevation infarct. Subendocardial involves inner 1/3 to 1/2 of the wall, tends to be smaller, and presentation is similar to unstable angina. Cardiac enzymes differentiate the two. Quick hit. STEMI diagnosis. ST elevation in 2 continuous leads of at least 1 millimeter, 1 small box in EKG. If the ST elevation is in V2 or V3, the threshold is higher, 2 millimeters in men, greater than 2 millimeters in men, greater than 40 years of age, greater than 2.5 millimeters in men, less than 40 years of age, and then 1.5 in women. It's the same thing we just mentioned before. Table 1.1 EKG findings based on location of infarct. Location of infarct and the EKG changes. So anterior with ST segment elevation in V1 through V4, acute/active. Q waves in leads V1 and V4, late change. Okay, so if you have an anterior infarct, you have those kinds of presentations on the EKG. What about a posterior infarct? Larger R wave in V1 and V2, ST segment depression in V1 and V2, upright and prominent T waves in V1 and V2. What about lateral infarct? Q waves in leads 1 and AVL, late change. What about inferior? Q waves in leads 2, 3, and AVF, late change. Note, augmented EKG leads from AVL indicate the left arm, and ones from the AVF indicate the left foot. Yeah. AVL means left arm, AVR means right arm, and then AVF means left foot. Now you can take a screenshot of that particular table. You might find a better one online. Next one, Clinical Pearl 1.4. Cardiac monitoring for a patient with an acute MI. Blood pressure and heart rate. Hypertension increases afterload and thus oxygen demand, whereas hypotension reduces coronary and tissue perfusion. Both nitrates and morphine can cause hypotension. Telemetry, cardiac monitoring. Watch for dysrhythmias. Note that PVCs can lower stroke volume and coronary artery filling time. A high frequency of PVCs, and these are like the, did they even say what they are? A high-frequency PVCs may predict VFib or ventricular tachycardia. Now, PVCs, I remember talking about this in the EKG course I'm talking about. PVC, heart, is called premature ventricular contraction. Okay. So basically, it's sort of this autonomous contraction of the ventricle. Or the ventricle is a premature contraction. Just be aware of that, okay? This might be an indication a high-frequency PVCs may predict VFib or ventricular tachycardia. Now, auscultate the heart, third and fourth heart sounds, friction rub, and so on. In lungs, crackles may indicate liver failure. Crackles may indicate left ventricular failure, and pulmonary edema. Hemodynamic monitoring, CVP, PCWP, SVR, cardiac index, CI, with a pulmonary artery catheter can be considered in unstable patients. Monitoring is helpful in assessing the need for IV fluids and/or vasopressors. I don't understand what compels them to do this. They do is a PCWP referring to capillary wedge pressure, but they never tell you that. You're supposed to know that. But I remember when they said, human immunodeficiency virus, HIV. Do people who are medical students, they all know offhand what PCWP means, but they don't know what HIV is. They have no idea what HIV is at all. It could be anything. So I don't know what the sort of inconsistency on explaining the acronyms that they like to utilize here. I'm not sure. Cardiac enzymes elevated in the setting of myocardial injury, figure 1.3. Troponin, and he also can't say that it was mentioned in an earlier chapter because this is chapter 1, so whatever. Anyway, cardiac enzymes elevated in the setting of myocardial injury, figure 1.3. Troponin I and T, are preferred tests when MI is suspected. High sensitivity troponin assays can be elevated within 2 to 3 hours of presentation. Routine troponin I and T assays can be elevated within 3 to 5 hours and return to normal in 5 to 14 days, peaks in 24 to 48 hours. Greater sensitivity and specificity than CKMB for myocardial injury. Obtain serum troponin level at presentation and 3 to 6 hours later. Troponins are highly sensitive and specific for cardiac injury. However, not all troponin elevations indicate myocardial infarction, for example, myocarditis, heart failure, etc. CKMB is less commonly used. It increases within 4 to 8 hours and returns to normal within 48 to 72 hours, reaches a peak within 24 hours. Troponin assays have mostly replaced the use of CKMB in clinical practice. So, yeah. Quick hit. Cardiac enzymes are drawn serially once on admission and gain in 3 to 6 hours. Once on admission and then again in 3 to 6 hours. The higher the peak and the longer enzyme levels remain elevated, the more severe the myocardial injury and the worse the prognosis. Quick hit number 2. The Capricorn trial showed that the beta blocker carvedilol reduced the risk of death in patients with post-MI left ventricular dysfunction. Again, you're supposed to know that left LV means left ventricle, but whatever. Treatment. See figure 1.4. The initial management of all patients. Hospital admissions on a floor with continuous cardiac monitoring. Establish IV access and give supplemental oxygen if patients are hypoxic. Monitor and aggressively replete electrolytes. Manage other complications as indicated, like arrhythmias per ACLS protocol, afterload reducing agents for heart failure, and so forth. Aspirin 325 milligrams and atorvastatin 80 milligrams. The Prove It TIMI 22 trial showed the superiority of starting atorvastatin 80 milligrams over other statins before discharging a STEMI patient. Nitrates for chest pain, which causes coronary dilation and increased oxygen supply to the myocardium. Nitroglycerin, first as a sublingual tablet or spray. If persistent pain, can start as an IV drip. Avoid if hypotension, right ventricular infarct or failure, or recent use of phosphodiesterase inhibitors like sildenafil. Morphine IV can be used with caution if ongoing pain and anxiety is not relieved by nitrates. Also causes venodilation and reduces preload. Give a beta blocker such as metoprolol if no hypotension or heart failure. Block stimulation of heart rate and contractility to reduce oxygen demand and decrease the incidence of arrhythmias. Reduce remodeling of the myocardium post-MI. So we have this thing here that says the multiples of MI threshold, and we have the days after onset of infarction. So the CKMB has a pretty short half-life, or has a pretty short, let's say, shelf life for the sake of it, and the troponins have lasted a lot longer. This also gives you an opportunity as a doctor, because let's say, for example, a patient had a heart attack, let's say a week ago, but they think they have a heart attack again today or yesterday. We can figure out whether or not there was a second heart attack based off the CKMB, because the CKMB is going to go kaput within 4 days, and it's going to peak in about a day or two. It looks like a day from this thing here, a little bit after a day. But the troponins are going to continue to being present all the way like 9 days afterwards. There might be some residual leftover troponins. And so troponins, in a certain sense, help us figure out and confirm if it was a while ago, it's been like over a week. But using both might help you differentiate it from a first heart attack from a second heart attack that might have happened not that long afterwards. You see what I'm saying? Because they have different, they remain in the body for different periods of time. So let's talk about the figure. Figure 1.3, evolution of serum biomarkers in acute MI. Curve M indicates the detection of myoglobin in the serum before other biomarkers. Serum CK, or CKMB, isoenzyme, begins to increase 3 to 8 hours after the onset of the acute infarct and peaks at 24 hours. Okay. Cardiac troponins are highly sensitive for myocardial injury and remain detectable in the serum for many days after the acute infarct. Oh boy. Give me a brief break. Okay. So here's this little diagram here: chest pain, chest pain / acute coronary syndrome. So it's here: common diagnosis or differential diagnosis: STEMI, NSTEMI, unstable angina, PE, aortic dissection, PTX, pericarditis, Boerhaave, anxiety, costochondritis, GI-related domestic violence. And you go to take an EKG, and you find is it STEMI criteria or semi-equivalent, or is it no STEMI criteria or semi-equivalent? And that goes into different categories of things, talking about cabbage, STEMI criteria. If you want to go review this, you want to take a screenshot, or maybe 2 screenshots, and merge them together. Be my guest. But I'll read this for you now. Chest pain, acute coronary. This is like a physical. This is like a visual algorithm, if you will. But anyway, it says here in the figure 1.4, chest pain, acute coronary syndrome. That's all it says. Okay, it is a little source for it. Okay. Treatment of NSTEMI and STEMI. Dual antiplatelet therapy with aspirin and a P2Y12 inhibitor, clopidogrel, ticagrelor, prasugrel. Anticoagulation with heparin or bivalirudin if undergoing cardiac catheterization, enoxaparin or fondaparinux for those not undergoing catheterization. Goal is to prevent the development of progression of a clot. Duration of treatment is at least 48 hours. Advanced therapies. Fibrinolysis, not beneficial in STEMI, should only consider in STEMI. For a STEMI, PCI is preferred for fibrinolysis as long as it can be performed within 120 minutes of presentation. Ideally, the percutaneous coronary intervention is performed within 90 minutes of the presentation, door to balloon time. Fibrinolysis is considered if the symptoms began within the last 12 hours. If PCI is not available within 120 minutes, fibrinolytics like alteplase or tenecteplase should be given within 30 minutes of the presentation. Revascularization. Some NSTEMI patients benefit from early coronary angiography and revascularization. New heart failure, cardiogenic shock, persistent angina despite medical therapy. Ventricular arrhythmias or other high-risk patients can use the STIMI or CRACE score to help identify and risk stratify. STEMI, all patients should undergo PCI, percutaneous coronary intervention. If it is readily available, it improves mortality and risk for a recurrent MI. After the acute treatment, continue aspirin or other antiplatelet therapy, beta blockers like metoprolol, nitrates, and statin therapy. Reduce risk factors, smoking cessation, weight loss, treat diabetes, hypertension, treat hyperlipidemia. Patients with any form of CAD should be started on HMG-CoA reductase inhibitor regardless of the LDL level. Clinical trial of statins have shown the efficacy of such therapy for secondary prevention in CAD. See Quick Hit on CARE trial. Cardiac rehabilitation is a physician-supervised regimen of exercise and risk factor reduction after MI and can reduce symptoms and prolong survival. Quick Hit. The following are the indicated in patients of MI: aspirin, P2Y12 inhibitor, nitroglycerin for chest pain, beta blocker, ACE inhibitor, inhibitor, heparin, oxygen if hypoxic, morphine if chest pain unrelieved with nitrates. Quick Hit. Right ventricular infarct will present with their inferior EKG changes, hypotension, elevated jugular venous pressure, hepatomegaly, and clear lungs. Preload dependent, do not administer nitrates or diuretics, as these can cause cardiovascular collapse. Quick Hit. The ESSENCE trial showed that, they love these names, these acronyms for these trials. The ESSENCE trial, the Capricorn, whatever. The ESSENCE trial showed that in unstable angina and non-ST elevated MI, risk of death, MI, or recurrent angina was lower in the enoxaparin group than in the heparin group at 14 days, 30 days, and 1 year. The need for revascularization was also lower in the enoxaparin group. Quick Hit. Thrombolytic therapy, fibrinolysis, has not been proven to be beneficial in unstable angina or in NSTEMI. This is only indicated in STEMI with no access to urgent catheterization for PCI. Now, not been proven is a very important phrase. Not been proven doesn't mean it's been disproven. It just says that it's not been proven. Quick Hit. Well, maybe it has been disproven, but they don't phrase it that way, so whatever. Quick Hit. The CARE trial, again, these acronyms here. The CARE trial, patients with prior history of MI are randomized to treatment with statins or placebo. The statin group had a reduced risk of death by 24%, a reduced risk of stroke by 31%, and a reduction in need for CABG of coronary angioplasty by 27%. Quick Hit. All patients initially treated conservatively, that is to say without revascularization, for the unstable angina / NSTEMI, should have a stress test before leaving the hospital to determine the need for angiography, which in turn determines the need for angioplasty or CABG. Where are we with this? Okay. I'm going to try to get through a quarter of this, and I'm going to go start rethinking my strategy with regarding to reading this book, because I'm beginning to think that this first chapter, which they want us to have on our study schedule to be across 2 different days, is over 100 pages, versus the chapters before, which were about 30 pages maybe, and then you'd read one 30-page chapter a day, you read another 30-page chapter the next day or something, maybe 20 pages long, and so you might read 50 pages between 2 different days. And they're a lot lighter in overall. And also, frankly speaking, this might be a bit offensive to the people who do, anatomy and physiology in general. But objectively speaking, this is less interesting than in my opinion. I mean, not objectively, but subjectively, it's more psychiatry is more interesting to me as a person than the heart. Just saying. But whatever. Let me trudge through at least a few more pages. Complications of acute MI. Pump failure, congestive heart failure, CHF, figure 1 through 5. Most common cause of in-hospital mortality. If mild, treat medically, ACE inhibitor, diuretic. If severe, may lead to cardiogenic shock. Invasive hemodynamic monitoring or support with inotropes or devices may be indicated. See cardiogenic shock on page 64. Arrhythmias. Premature ventricular contractions, PVCs, conservative treatment, observation indicated. No need for antiarrhythmic agents. AFib. Ventricular tachycardia, VT. Sustained ventricular tachycardia requires treatment if patient is hemodynamically unstable. Electrical cardioversion is indicated. If the patient is hemodynamically stable, start antiarrhythmic therapy. See treatment of ventricular tachycardia. VFib, immediate unsynchronized defibrillation, and CPR are indicated. See arrhythmias on page 21. Accelerated idioventricular rhythm does not affect prognosis. No treatment needed in most cases. Paroxysmal supraventricular tachycardia or PSVT. For treatment, see arrhythmias, sinus tachycardia. May be caused by pain, anxiety, fever, pericarditis, medications, etc. Worsens ischemia, increases myocardial oxygen consumption. Treat underlying causes, analgesics for pain, acetaminophen for fever, etc. Sinus bradycardia, a common occurrence in early stages of acute MI, especially right-sided/inferior MI. May be a protective mechanism, reduces myocardial oxygen demand. No treatment is required other than observation. If bradycardia is severe or symptomatic hemodynamic compromise, atropine may be helpful in increasing the heart rate. Asystole, very high mortality. Treatment should begin with electrical defibrillation for VFib, which is more common if cardiac arrest and may be difficult to clearly differentiate from asystole. If asystole is clearly the cause of the arrest, transcutaneous pacing is the appropriate treatment. AV block, associated with ischemia involving conduction tracts. First and second degree type 1 blocks do not require therapy. Second or type 2, third degree blocks, prognosis is dire in the setting of an anterior MI. Emergent placement of a temporary pacemaker is indicated with later replacement of a permanent pacemaker. In inferior MI, prognosis is better and IV atropine may be used initially. If conduction is not restored, a temporary pacemaker is appropriate. Can be used positive chronotropic medications to maintain heart rate and blood pressures, that is to say isoproterenol and dopamine, while awaiting placement of temporary pacemaker. So here's MI, ventricular thrombus, embolism, contractility, causing hypotension, coronary perfusion declining, and then increased ischemia, which causes decreased contractility, and it's a cycle. It's a ruthless cycle called cardiogenic shock, congestive heart failure. That's pretty nasty. Electrical instability causing arrhythmias, and you also have tissue necrosis, which goes related to the decreased contractility, and related to each other. This can cause things like expansion of the infarct, which causes CHF or shock, papillary muscle infarction or ischemia, which leads to mitral regurg. You're going to get ventricular septal defect, which causes CHF or shock. You can have ventricular rupture, which causes cardiac tamponade, or you can have pericardial inflammation, which causes pericarditis, which causes cardiac tamponade. So that's the figure 1 through 5, cardiac complications of MI. The answer is it's not very good. Oh boy. Honestly, let me just finish this right here. I could say, for example, I should continue until this last portion, but I'm beginning to think really, based off of reading this for over an hour, that this is a very, compared to what we were doing before, a very dense textbook, and subjectively speaking, comparatively, I just don't like reading it. I really don't. I could read probably 2 hours or I could read an hour and 9 minutes of psychiatry, and I would be fine. And I'd say, wow, this is really interesting. This is talking about, whatever, psychological state that's pathological, and I would be, this is really interesting. I do not feel the same way about the heart. Sorry, and I do not feel that way about most of the anatomy and physiology in general. It's its own beast. And this is much longer, and it is what it is, So I'm going to say that I'm going to call it quits for today. And maybe I might just quit on reading the book entirely and switch over to either watching videos myself or some other technique for actually going over all the material, because this is a little inside scoop. Here's a little insider, a little trick for you right now. They are not going to check whether or not you read the textbook. They're not going to ask. Maybe they do ask you, but normally they won't. They're not going to have a situation where you're tested on the material. You're not tested on whether or not you read it. You see what I'm saying? So there may be other sources, either videos or other textbooks that are more brief. Hint, hint, step 1's a good example, because step 1, I was thinking about this before. Wow, this is a very broad topic. I need to go read everything. I got to go read cardiovascular, and I got to go read GI, and I got to go read all these other topics. And it's like, yeah, I do have to read all those topics again. Or some of them I never read in the first place, but whatever. I never read the step 1 textbook for some sections. However, it's a lot more brief than this textbook, which is, I think, in many ways more dense. And it's more clinical, to be fair. Now, you should know clinical stuff, but I feel like some of this stuff is a little bit over the top, maybe you could say. I wouldn't mind reading a brief version of this where I just read like the heavy-hitting facts and clinical pearls or whatever. But I'm really feeling that this isn't going to be a waste of my time, given that, if you're a medical student, time is of the essence. It's its own valuable resource. And honestly, there's a lot of things, including stuff they recommend to you from either other students or from medical professors who are not the ones who are actually taking the exams anyways, who say, oh, you should read the textbook. This is the required textbook. Okay, whatever. Anyway, hopefully this video is useful for you. I think it has maybe potentially enlightened me as to the utility of reading this textbook in the first place. And I feel maybe the reason that I was so adamant and willing to read some of the sections before in these other textbooks, certainly for psychiatry, where I felt like I really had a lot of stamina with it, is because it was actually interesting for me, again, subjectively speaking. But anyway, hopefully you have a great, wonderful rest of your day. Thank you, and goodbye.